Welcome to another episode from the Veterinary Medicine Digest. Today we are diving deep into a topic that, while common, remains a significant source of emergency calls and potentially devastating outcomes for our beloved companion animals: rodenticide poisoning. These poisons, designed to eliminate pests, unfortunately, are among the most frequently encountered toxins by dogs and cats, second only to insecticides in prevalence among pesticide exposures. We are focusing on the 5 most commonly reported types in the United States: the anticoagulant rodenticides, bromethalin, cholecalciferol, strychnine, and zinc phosphide. Understanding how these different chemicals operate, how they affect our pets, and crucially, how to treat them, is paramount, especially since the regulations governing which products consumers can purchase have changed dramatically in recent years. We've seen a recent shift in the landscape of rodenticide exposures in veterinary clinics. Following risk mitigation rules issued by the Environmental Protection Agency in 2008 and enforced by 2011, manufacturers were required to phase out certain second-generation anticoagulant rodenticides from consumer products. This means that while older products containing these potent second-generation compounds might still be in use, new consumer products now often contain first-generation anticoagulants, or non-anticoagulants such as bromethalin and cholecalciferol. This change in the market is strongly predicted to cause an increase in the number of toxicoses cases involving bromethalin and cholecalciferol seen by veterinarians. In fact, reports indicate that bromethalin exposure cases in dogs have surged dramatically since 2010, now accounting for over 50% of rodenticide exposure calls, far surpassing anticoagulant rodenticides. This shifting balance means accurate identification of the toxic agent is more critical than ever, since the treatments and prognosis vary widely. Let's begin our detailed exploration with the most historically common and widely known group, the anticoagulant rodenticides. Anticoagulant rodenticides, the silent internal bleed. Anticoagulant rodenticides were first developed following the discovery of dicumarol, the agent responsible for sweet clover poisoning in cattle, which caused internal bleeding. The resulting chemical, warfarin, was the first anticoagulant rodenticide marketed. These compounds are broadly divided into 2 groups: first generation and second generation. First generation compounds, such as warfarin, chlorofascinone, difascinone, and cumatetrolil, were developed in the 1940s and 1950s and typically required multiple exposures for effective rodent control. Unfortunately, rodents developed resistance, prompting the creation of second generation compounds. These second generation anticoagulant rodenticides, which include brodifacoum, bromadiolone, difenicum, difethialone, and flucomafin, are far more potent, are often longer acting, and were formulated to be effective after only a single feeding. Since the Environmental Protection Agency restrictions, consumer products largely feature first-generation compounds, or non-anticoagulant agents, while the more restricted second-generation compounds are reserved for professional pest control. The way these anticoagulants wreak havoc is fascinating and involves a key metabolic process in the liver. Once ingested, they are transported to the liver, where they interfere with the recycling of vitamin K1-hydroquinone. Vitamin K1-hydroquinone is essential because it is required for the synthesis of functional forms of 4 critical clotting factors: factors 2, 7, 9, and 10. During the creation of these factors, vitamin K1-hydroquinone is converted into vitamin K1 epoxide. Normally, 2 enzymes, vitamin K1 epoxide reductase and dedidiaphorase, work sequentially to convert the vitamin K1 epoxide back into the active vitamin K1 hydroquinone form, effectively recycling it. Anticoagulant rodenticides inhibit this recycling process to varying extents. When recycling is inhibited, dysfunctional forms of the clotting factors are released into the circulation, eventually leading to a coagulopathy, or a bleeding disorder. The onset of clinical signs is usually delayed because the body must first deplete the clotting factors already present in the circulation. In dogs, these clotting factors have different half-lives. For example, factor 7 has a very short half-life of about 6 hours, while factor 2 has a half-life of about 42 hours. Because of this decay process, laboratory tests often detect prolonged clotting times between 18 to 24 hours after a toxic exposure in dogs, but the visible, external clinical signs of a coagulopathy are typically noticed much later, usually 2 to 5 days after exposure. When a pet is exposed, the toxic dose varies significantly depending on the specific compound and the species. Fortunately, the likelihood of a dog or cat experiencing secondary, or relay poisoning, that is poisoning from consuming a rodent that was itself intoxicated, is generally considered limited. The concentration of the anticoagulant found in the rodent's tissues is substantially lower than that found in the bait. A dog, for example, would need to consume a substantial number of poisoned rats to receive a toxic dose, such as eating approximately 500 grams, or slightly more than 1 pound, of rat per kilogram of body weight to reach a toxic dose of brodenticide. However, in specialized scenarios, such as a small barn cat relying on rodents as its main food source, relay toxicosis is theoretically possible. The presentation of anticoagulant rodenticide toxicosis can be categorized as either classic or atypical. Classic signs are often observable by the owner and include external evidence of bleeding, such as blood in the urine, blood in the vomit, or nose bleeds. Owners may also report vague signs like depression, lethargy, or a reduced ability to exercise. Upon physical examination, a veterinarian might observe pale mucous membranes, hemorrhages inside the mouth, prolonged bleeding from venipuncture sites, coughing or blood-tinged sputum. Respiratory distress, or dyspnea, is a common finding, which can be radiographically clarified as intrapulmonary hemorrhage or bleeding into the chest cavity, known as hemothorax. For pets presenting with these classic signs, the prognosis is often good if treatment is timely, with survival rates reported between 80 and 100%. Atypical clinical signs, however, often delay the correct diagnosis because they do not immediately suggest an anticoagulant exposure. These atypical presentations can include uterine hemorrhage, acute mediastinal hemorrhage, or simply lack of appetite. In the experience of some veterinary professionals, dogs exposed to anticoagulant rodenticides might also exhibit vomiting, cardiac murmurs, ataxia, stiffness, or even seizures resulting from internal bleeding within the spinal cord or brain. A case described a 5-month-old dog with neurologic signs including ataxia, a head tilt, and altered mentation, along with clinical bleeding, scleral hemorrhage and bleeding at venipuncture sites, which was confirmed to be anticoagulant rodenticide toxicosis. Because recognizing the cause of atypical signs is often delayed, the prognosis is substantially worse in these cases compared to those with classic signs. Diagnosis of anticoagulant rodenticide poisoning is typically based on the history of exposure and the presence of compatible clinical signs. When history is unreliable or unavailable, laboratory tests become essential. 3 main types of supportive tests are used in live animals: coagulation tests, the proteins induced in vitamin K1 absence test, and analytic detection of the compound itself. Coagulation tests are crucial. Common tests include the activated clotting time, prothrombin time, and activated partial thromboplastin time. The prothrombin time primarily measures the extrinsic clotting pathway and is the first to become prolonged, typically within 36 to 72 hours of ingestion, due to the rapid depletion of factor VII. As the toxicosis progresses and other factors are depleted, the activated clotting time and activated partial thromboplastin time, which measure the intrinsic clotting cascade, also become prolonged. A prothrombin time longer than 10 seconds in dogs or 12 seconds in cats supports an extrinsic pathway coagulopathy, while an activated clotting time longer than 125 seconds in dogs or 105 seconds in cats indicates an intrinsic pathway coagulopathy. The proteins induced in vitamin K1 absence test has become a useful diagnostic tool, as it detects the dysfunctional clotting factor proteins produced when vitamin K1 hydroquinone is deficient. A prolonged test time supports a vitamin K1 responsive coagulopathy. For the highest degree of medical certainty, analytic confirmation of the anticoagulant rodenticide compound in the animal, coupled with evidence of a coagulopathy that responds to vitamin K1 treatment, is ideal. Specialized techniques like high-performance liquid chromatography and gas chromatography tandem mass spectrometry are available to measure the concentration of the rodenticide in serum, blood, or liver. This chemical analysis is particularly important in cases with legal implications, or when confirming exposure is necessary, due to an absent or unreliable history. Treatment focuses entirely on providing functional clotting factors. In symptomatic animals experiencing an acute hemorrhagic crisis, immediate stabilization is key, which often requires transfusions of fresh frozen plasma or whole blood to rapidly replenish functional factors. The dosage is often 9 milliliters per kilogram for plasma or 20 milliliters per kilogram for whole blood. The cornerstone of long-term therapy is vitamin K1, which acts as the antidote. The recommended dose is typically 2.5 to 5 milligrams per kilogram administered orally, once or twice daily, and must be given with a fatty meal to enhance absorption. Vitamin K3, however, is contraindicated because it is ineffective and can cause hemolytic anemia characterized by Heinz bodies. It is crucial to administer the vitamin K1 for the duration determined by the specific anticoagulant involved, which correlates to the toxin's elimination rate. Warfarin, a short-acting first-generation compound, requires a shorter treatment duration, typically 2 weeks. In contrast, the more persistent second-generation compounds necessitate much longer treatment, often 3 to 4 weeks. In asymptomatic pets with known recent exposure, decontamination is the first step. This involves removing any remaining bait from the environment and administering an emetic, such as apomorphine in dogs or xylazine or dexmedetomidine in cats, unless contraindicated by signs like seizures or severe depression. Emetics are usually effective if administered within the first 1 to 2 hours post-ingestion for these toxins. Following emesis, an adsorbent like activated charcoal should be administered orally. Caution must be exercised with administering injectable vitamin K1 because of the risk of creating a hematoma or inducing a possible anaphylactic reaction. Therefore, the oral route is highly preferred. Monitoring the prothrombin time 48 to 72 hours after the last dose of vitamin K1 is critical to ensure the coagulopathy has resolved, and that therapy does not need to be extended, which is often necessary after massive ingestions. Recent veterinary studies employing specialized ultra-high-performance liquid chromatography tandem mass spectrometry techniques have provided remarkable insights into the elimination kinetics of these long-acting compounds. Analysis of samples from poison dogs has demonstrated that anticoagulant rodenticides are primarily eliminated through bile and detected in feces. Notably, the terminal elimination half-lives of second-generation compounds are extremely prolonged. Brodifacoum, for example, has been found to persist in a dog's feces for at least 969 days after the initial exposure, with estimated terminal half-lives ranging from 200 to 330 days. Similarly, difenicum persistence was estimated to be at least 653 days after ingestion, with a terminal half-life of 190 days. Bromadiolone, while still long-acting, showed a significantly shorter terminal half-life in feces, estimated at 30 days. This extensive persistence, confirmed via fecal analysis, a non-invasive and reliable method, is crucial for determining the necessary treatment duration and highlights the environmental burden of these compounds. It also confirms that these drugs are stored in different tissues for months after a single ingestion. Furthermore, brodifacoum was detected in the feces of puppies born to an exposed bitch for at least 28 days after birth, suggesting potential perinatal exposure, although the puppies remained clinically healthy. Bromethalin, the threat to the nervous system. Now let's turn our attention to bromethalin, a neurotoxin whose use has significantly increased since the Environmental Protection Agency limited the use of certain second-generation anticoagulant rodenticides. In 2016, bromethalin was reported as the most common cause of calls to a national poison control hotline in 17 states. Bromethalin is rapidly absorbed from the gastrointestinal tract and metabolized in the liver to its more toxic metabolite, desmethylbromethalin. Because of its highly lipophilic nature, both bromethalin and desmethylbromethalin concentrate highly in fat and the brain. The mechanism of action is distinctly different from anticoagulants. Bromethalin interferes with cellular energy production by uncoupling oxidative phosphorylation in the mitochondria, leading to a severe reduction in available adenosine triphosphate. Without sufficient adenosine triphosphate, the sodium-potassium adenosine triphosphate pumps fail. This failure causes sodium to build up inside the cells, resulting in a passive influx of water, leading to cytotoxic edema and swelling, particularly in the myelinated white matter of the brain and spinal cord. This swelling increases intracranial pressure and causes neuronal damage. Cats are much more sensitive to bromethalin than dogs, with a minimum lethal dose reported at 0.45 mg per kilogram, compared to 2.5 mg per kilogram in dogs. However, dogs have developed clinical signs at doses as low as 0.36 mg per kilogram. Clinical signs of bromethalin toxicosis are dose-dependent and typically manifest as one of two syndromes. High-dose exposures, often at or above the median lethal dose, lead to a rapid-onset convulsant syndrome, often within 4 to 18 hours of ingestion. Signs include hyperesthesia, hyperexcitability, tremors, seizures, central nervous system depression, and potentially death from respiratory paralysis. Lower doses typically result in a paralytic syndrome, characterized by a slower onset of 1 to 7 days. These animals may initially show ataxia, paresis, or paralysis of the hind limbs, potentially mimicking spinal cord compression, progressing to recumbency, depression, and a comatose or semi-comatose state. Other signs may include hypothermia, hypersalivation, vomiting, diarrhea, nystagmus, and opisthotonus. Once severe signs like seizures, coma, or paralysis are present, the prognosis is considered poor to grave. Diagnosis is challenging because there is no routinely measurable clinical chemistry biomarker. Diagnosis relies heavily on a history of exposure and compatible clinical signs. Post-mortem diagnosis can be confirmed by detecting dis-methylbromethalin residues in tissues, particularly fat, kidney, liver, or brain. Because bromethalin and its metabolite are highly lipid-soluble, fat is considered the ideal tissue for analysis. While experimental models typically show diffuse vacuolar spongiosis, spongiform change, of the white matter in the central nervous system, clinical cases of bromethalin intoxication may lack this classic histologic lesion, making chemical detection of dis-methylbromethalin essential for confirmation. Furthermore, meningeal hemorrhages have been reported as an atypical finding in some cases, which might be related to hyperthermia from severe muscle tremors or hypernatremia induced by treatment. Treatment lacks a specific antidote, so therapy focuses on decontamination, supportive care, and managing central nervous system swelling. Emetics are contraindicated if the animal is seizing or comatose, in which case sedation and gastric lavage may be substituted. Activated charcoal is routinely recommended due to the enterohepatic recirculation of bromethalin. However, repeated doses of activated charcoal carry the risk of inducing hypernatremia, which can cause or exacerbate central nervous system signs like ataxia and seizures, potentially masking or complicating the diagnosis of bromethalin toxicosis itself. One dog treated with activated charcoal was documented to have a serum sodium concentration of 168 millimoles per liter just minutes before death, illustrating this severe risk. Supportive care for symptomatic animals includes managing cerebral edema, using osmotic agents. Mannitol, 0.5 to 1 gram per kilogram intravenously, or furosemide may be used, often combined with dexamethasone. However, the effects of mannitol are transitory, and signs may return once the therapy is discontinued. Sedation with drugs like pentobarbital or methocarbamol may be necessary to control tremors and seizures. A promising area of treatment, especially considering the high lipophilicity of bromethalin, log P of 6.2, and dis-methylbromethalin, predicted log P of 6.6, is the use of intravenous lipid emulsion therapy. Intravenous lipid emulsion is hypothesized to create a lipid sink in the plasma, sequestering the fat-soluble toxin away from the central nervous system tissues. One case report in an asymptomatic dog demonstrated a rapid 75% reduction in serum dis-methylbromethalin levels, from 4 parts per billion to 1 part per billion in 1 hour, following intravenous lipid emulsion administration. Furthermore, a dog presenting with severe symptomatic bromethalin toxicosis, including seizures and cranial nerve deficits, successfully recovered after treatment combining intravenous lipid emulsion, mannitol, and ginkgo biloba extract. Ginkgo biloba extract is thought to have hypoxia protective effects and may help reduce cerebral lipid peroxidation. Given the otherwise poor prognosis for severe bromethalin toxicosis, these therapies, intravenous lipid emulsion, osmotic agents, and ginkgo biloba, offer viable options for aggressive intervention. When using intravenous lipid emulsion, clinicians must remember that other lipophilic medications, like phenobarbital, may also be sequestered and rendered less effective, making alternative anticonvulsants like levetiracetam a better choice. Cholecalciferol, the vitamin D overdose. Next, we address cholecalciferol, also known as vitamin D3, which is another non-anticoagulant rodenticide whose use is rising. While vitamin D3 is an essential fat-soluble vitamin that can be synthesized in the skin or obtained through the diet, toxicosis occurs when excessive amounts are absorbed. The fundamental issue in cholecalciferol toxicosis is severe hypercalcemia. Once ingested, cholecalciferol is converted first by the liver into calcifediol, or 25-hydroxycholecalciferol. This conversion has limited negative feedback, so large ingestions lead to significant levels of calcifediol. This metabolite is then converted by the kidney into the most active form, calcitriol, or 1,25-dihydroxycholecalciferol. Calcitriol increases serum calcium and phosphorus concentrations through 3 main actions: increased absorption of calcium from the gastrointestinal tract, enhanced resorption of calcium and phosphorus from bone, and reduced excretion of calcium in the urine. Elevated calcium and phosphorus levels harm excitable tissues and, critically, lead to soft tissue mineralization throughout the body. The kidneys are often severely affected, resulting in hypercalcemic nephropathy and acute renal failure, typically within 24 to 72 hours of exposure. Mineralization is also commonly seen in the lungs, stomach, heart, myocardium, and blood vessels. Clinical signs usually begin within 12 to 36 hours of ingestion. They can include anorexia, vomiting, sometimes with blood in the vomit, depression, weakness, excessive drinking, and excessive urination. The toxic dose in naturally intoxicated dogs has been reported as low as 1.5 to 3 milligrams per kilogram. Diagnosis relies on history and the characteristic laboratory findings of hypercalcemia, hyperphosphatemia, and potentially azotemia, increased blood urea nitrogen and creatinine. In cats, hyperkalemia and acidosis have also been reported. For confirmation, measuring the serum concentration of 25-hydroxycholecalciferol is proposed. Levels must be elevated at least 15 times the normal amount to confirm excessive exposure. The goal of treatment is to aggressively lower serum calcium levels. For asymptomatic animals presenting shortly after exposure, decontamination is recommended via induced emesis and the administration of activated charcoal. Because cholecalciferol undergoes enterohepatic recirculation, cholestyramine resin or repeated doses of activated charcoal may be employed to bind and remove the compound. For symptomatic animals, rehydration and forced diuresis are primary interventions, using a calcium-free fluid like 0.9% sodium chloride at 2 to 3 times the maintenance rate. Sodium ions are critical because they enhance calcium excretion by reducing its reabsorption in the renal tubules. Loop diuretics such as furosemide further enhance this excretion. Glucocorticoids like prednisone also aid treatment by suppressing bone resorption, reducing intestinal calcium absorption, and increasing urinary calcium excretion. It is important to avoid thiazide diuretics, as they can decrease calcium excretion. If hyperphosphatemia is present, oral phosphate binders like aluminum hydroxide are beneficial. The patient should also be fed a low-calcium, low-phosphorus diet for at least 4 weeks. If the hypercalcemia is severe or refractory to standard fluid and diuretic management, more aggressive therapies are needed. The preferred treatment is pamidronate disodium, a bisphosphonate administered slowly intravenously. Pamidronate works by inhibiting bone resorption and is highly effective, usually reducing calcium levels within 24 to 48 hours. Calcitonin salmon is an alternative but less desirable option. It has a very short half-life and its effectiveness is inconsistent, and animals often become refractory to it quickly. Importantly, combining pamidronate and calcitonin is not recommended in veterinary patients, as studies have not shown benefit, and may potentially worsen soft tissue mineralization. Because the half-life of cholecalciferol is very long, around 29 days. Monitoring and treatment may be required for several weeks. Strychnine and zinc phosphide. Acute and dangerous. Finally, let's briefly touch upon 2 other highly hazardous rodenticides, strychnine and zinc phosphide. Strychnine is a restricted-use pesticide, often found in baits as red or green-colored grains. It is rapidly absorbed and distributed throughout the body. The toxin acts by inhibiting the neurotransmitter glycin in the Renshaw cells of the central nervous system. This inhibition leads to a loss of inhibitory control, causing animals to receive excessive sensory input and exhibit exaggerated motor responses. Clinical signs are rapid, appearing within minutes to a few hours, starting with apprehension, tension, and stiffness. This quickly progresses to tonic extensor rigidity, which can be triggered by external stimuli like light, sound, or touch. Animals often die from hypoxia because the respiratory muscles become paralyzed in a rigid, arched posture known as opisthotonus. Diagnosis must be confirmed analytically, as many other diseases including rabies, tetanus, or certain mycotoxins can mimic these severe signs. The primary treatment goal is sedation using agents like pentobarbital or methocarbamol to prevent seizures and muscle activity until the toxin can be metabolized. Activated charcoal can be administered if seizures can be avoided. Zinc phosphide is a restricted-use, acutely toxic pesticide. Its danger arises when it is exposed to moisture and the acidic environment of the stomach, where it releases phosphine gas. Phosphine gas is described as a general protoplasmic poison. Clinical signs include vomiting, convulsions, aimless running, and death. Animals may exhibit bloat due to the gas release, and the characteristic odor of phosphine may be noticeable on the breath or in the stomach contents. Since no specific antidote exists, treatment focuses on removing the chemical from the stomach via emetics, reducing the liberation of phosphine gas by gastric lavage using 5% sodium bicarbonate, and providing supportive care for the liver and fluids. Concluding thoughts on rodenticide toxicosis. In summary, rodenticides present a complex and ever-changing toxicologic challenge in veterinary medicine. The shift away from easily treatable second-generation anticoagulant rodenticides in consumer products means veterinarians must increasingly be prepared for bromethalin, which lacks an antidote, and cholecalciferol, which requires prolonged and aggressive management. In all cases of exposure, rapid identification of the active ingredient, whether through consulting packaging, performing coagulation tests, or using high-end analytic tools like ultra-high-performance liquid chromatography tandem mass spectrometry, is essential for determining the correct and most effective therapeutic plan and predicting the patient's prognosis. For the anticoagulant rodenticides, the prognosis is often excellent if the life-saving antidote, vitamin K1, is administered promptly and correctly. However, bromethalin toxicosis carries a much more guarded prognosis once clinical signs emerge, though novel therapies like intravenous lipid emulsion show great promise. Finally, for any rodenticide exposure, early decontamination through emesis and activated charcoal, when appropriate, remains a crucial first line of defense, potentially averting a severe or fatal outcome. Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.